Mhm.
Recording to the cloud.
Okay.
Recording to the cloud.
All right, thank you. I see it says live.
Yes.
Okay, thank you so much, Edith. I appreciate it. Good evening. Welcome to the House Health and Government Operations Committee. Delegate Shane Pendergrass is the chair. I'm the vice chair. And this is the Public Health and Minority Health Disparities Subcommittee. Our counsel is the wonderful Erin Hopwood, and I have my wonderful team member, Edith Perry, who is staffing tonight, and Marian Amsi. I want to thank the committee for coming this evening on Saturday. We have a full agenda, so we're going to get started. And thank you so much for making time for us. We're going to start with House Bill 96. House Bill 96 is Public Health, Non-Discrimination, and Access to Anatomical Gifts and Organ Transplantation Financial Status. We have, I know I have been speaking with Delegate, one second. Yeah, I'm sorry. Yes, I'm like having a mental or freeze there. Delegate Shetty and the Hospital Association regarding the bill. So what we're gonna do is she on today? What we're gonna do is basically, I see Brian from the Frazee from the Hospital Association and Delora as well. Elizabeth from Johns Hopkins. And if I miss anyone else, forgive me. What we decided to do is that we're going to hold the bill. We're working on a meeting with Delegate Shetty and myself and the hospital associations to discuss the bill and see what we're able to do. I had a meeting with them on Friday, and I'll make myself available again this week to see how we move forward. So just wanted to let you know that, okay? And that is our commitment. And we're going to hold it for now. I know you're working on getting a meeting with my office and Delegate Shetty's, correct?
Yes, that's correct, Delegate. We're scheduling it on Friday, I believe. Just
Okay,
got started.
Wonderful. So I'll be available and we'll see what we can do. And thank you so much for your willingness to work with our members. We really appreciate it, okay?
Thank you all. We
Thank
appreciate it.
Our pleasure. Thank you for being here. So next we have House Bill 129, Behavioral Health Crisis Response Services and Public Safety Answering Points Modification. That is Delegate Lori Charkoudian's bill. Erin, will you tell us what this bill does? And then Delegate Charkoudian, I'm going to call on you to tell us the posture of the bill in the Senate and the amendments, okay? So get ready, Erin.
There is a reprint of the bill on pages 1 through 7 of your packet. The bill requires the Maryland Department of Health, in awarding grants from the Behavioral Health Crisis Response Grant Program, to require that proposals include response standards that prioritize mobile crisis teams over law enforcement when responding to individuals in crisis. Each public safety answering point must develop a written policy that includes certain procedures. And there's also an amendment that requires certain training in those procedures. So those amendments are on pages 1 through 7 of your packet.
Okay, and I know Erin sent you a couple of emails with the reprints, so you have it in your email. Delegate Charkoudian.
Great, thank you. So the first amendment, which is changing from on page 3, line 22, changing to the language prioritize mobile crisis units over law enforcement as opposed to minimize law enforcement, which hopefully you have that language. That was as a result of, folks might recall that MACO came in favorable with amendments. There was no opposition, but MACO came in favor with amendments. We spent some time with them and accepted this amendment. The bill that passed out of the Senate, 45-0, included this amendment from MACO. The second
in your packet, sorry, it's on handwritten 3, line 23.
Sorry, I'm not looking at your packet. I'm just looking at the amendment. My apologies. Does everyone have that? Or okay,
the members do. Yeah.
So the second amendment came as a result of Delegate Sample Hughes's question about training. And so in the section that's related to the plans that the the 911 call systems need to develop. We added a line about that plan that has to be made public also includes training for applicable staff on implementing the procedures. So I discussed that with Delegate Sample Hughes, and she felt like it took care of the issue that she was raising. And so those are the two amendments that you have.
Aaron, can you tell
That's
us
reflected
where
on
they are?
handwritten.
Hold on
page
1
7.
second, please. Yeah. Well, go ahead, Erin. I couldn't hear you.
That training component's reflected on handwritten page 7, after line 2.
Okay. And those are the only two amendments, Delegate Sharkoudian?
That's it. I should clarify, the First Amendment was passed in the Senate. That's like, I'll call it the Mako Amendment. That was passed in the Senate. The Second Amendment was not on the bill that passed the Senate because it came up in the House and I hadn't developed the amendment. They moved very quickly in the Senate. So I think I've spoken to the Senate sponsor and he's perfectly fine with that amendment. So I think they would just conform if we pass it with the training amendment.
Wonderful. Are there any questions, Delegate Shalega? Did you have a question?
Yes, thank you. Erin chimed in. I was trying to follow. I knew she would tell us. I'm sorry. She waited for her. I do have a question. Hold on. Let me go back to the document. Hold on. On bill page 5 of 7, which is handwritten page 5, line 17 and 18. Limiting the interaction of law enforcement with individuals in crisis. I'm just wondering why that's necessary since you set it up above in your other amendment.
May I answer, Madam
Yes,
Chair?
Delegate Sharkoudian.
Thank you for the question. So there's two different sections of the statute that we're writing to here. So one of the sections, the one up above where we did the Mako amendment, is the one that's related to this particular grant and how grant applications get considered. This second one, and those grants are for any number of crisis response things, like it could be for mobile crisis units, it could be for a walk-in crisis center, right? It goes to any number of crisis response programs. This section is where the state statute defines what a mobile crisis team is for any other places where mobile crisis teams might be used as a response. And so there was a need to put in the definition the nationally recognized best practices, which is that while they might be working in collaboration with law enforcement, the actual design of a mobile crisis unit is designed so that that you're not that you're prioritizing a mental health response to a mental health crisis.
How would this relate to, so Baltimore County Police has 2 current mobile crisis teams, one on that covers the whole county. They just split them east and west. And it is through the Baltimore County Police Department. It's really working well. Law enforcement is working with some behavioral health specialists. The police are part of the team. They don't wear a police uniform. You know, they wear civilian clothing. And it would be great. I mean, it's a great model that's really working well. Why? This bill seems like it would disadvantage them.
So I think, sorry, Madam Chair, I'm not sure.
Yes, you can. Yes, you can answer all the questions. Mm-hmm.
So first of all, as it relates to this question about disadvantaging, the language, this was, I think, the concern that Mako had about counties that had different kinds of models. And that was where particularly in the grant award, it was that language was changed. This is the place where we're establishing what best practices are. And the reality is that I can just speak to Montgomery County, where they don't follow best practices for their mobile crisis unit. They do send police all the time and police knock first. And that is not a best practice, and is really important as a state that we establish what the best practices are and not set our state best practices to respond to what our local communities are doing. So presumably, The change that would have to be made is then there would have to be a thoughtful triage process and a decision point in the same way that you do with other crises where you're deciding about sending, fire trucks and so on. But there would have to be continued collaboration if that's what the locals decide, but you wouldn't have a de facto police are always going to knock first policy. That wouldn't be okay. And that shouldn't be okay, because when someone's suffering a mental health crisis and the other signs of physical danger for folks aren't happening, it is actually considered a bad practice and potentially could make it worse if you have law enforcement responding as opposed to someone who's trained in handling mental health crises. So,
So what about police that are trained in that are responding in civilian clothes, that are collaborating with? So you're, just because they don't do it right in Montgomery County doesn't mean that we're not doing it right in Baltimore County. And so, I'm concerned that you're getting rid of a model that seems to be working really well. If they show up in this, unmarked car in civilian clothing, they're, the police are working with mental health professionals. I don't know why that couldn't be a good model. And your build, through these languages, disadvantages them to growing that program. And, instead of looking at it and saying, hey, this actually might be a good program. I mean, you look in New York 2 weeks ago, the police responded to a mental health crisis and the person killed his mother and 2 of the police officers and injured a third. So, I mean, you do need some law enforcement to, trained people trained to use a firearm and know how to protect the public. I'm assuming if in some or many cases.
So, if I may respond, Madam Chair.
Yes, and then Delegate Hill has a question. Go ahead.
Sure. So this isn't necessarily what I think is best, right? This is sort of national best practices about responding to mental health crises, the vast majority of which are not physically dangerous, are not situations. They're upsetting, they're disturbing. I mean, I've got someone with a severe mental health illness in my family. And there have been times, I'll just tell you, there's been times that I have called the police, but there's been other times I've needed help that I knew I didn't need the police. And the only way I could get help was to end up with police coming and potentially making it worse. So there are many mental health crises where a family member needs help and frankly won't call for the help that they need until things have escalated and gotten much worse, potentially risking a suicide, potentially risking, further sort of crisis spiraling for somebody because they're afraid of what's going to happen if the police come. And so because of that, the de facto, we always bring the police and I will say that a few years ago, we passed a CIT bill. It was my bill. I think that there is a role for training police on how to respond when police are needed in a mental health crisis, but that doesn't mean that every mental health crisis needs police. And that's the distinction here is we need to be thoughtful about what service we're responding to, recognizing that police, trained or untrained, may make things worse, may result in criminalization of behavior that's not criminal. And so when it's appropriate to bring police should come, but we shouldn't have a de facto plan that because there's a mental health crisis, police ought to be involved. And that's really what this line is about.
Okay, I guess I might say they don't. Okay, thank you.
I have Delegate Hill followed by Maura Cyphers.
Thank you, Madam Chair, and thank you for this bill, Delegate Tarkoudian. And as I understand it, I'm also represent Baltimore County. We've got a mobile crisis team, as Delegate Shalega said. And our chief of police actually was before us on Friday talking about how it's good, but it's not good enough, and they need to have more behavioral health specialists as well. And so with this, as I understand it, it doesn't say you can't use police. It says let's have a plan. Let's have some protocols and policies so that we know when the police coming as the initial contact, as a support contact, what that means, what that looks like, when they are on standby and not at site, that it gives us more tools. And it's not just about as you said, first of all, the vast majority of these cases don't end up in the newspaper, don't end up, they end up problematic, but not the stories that we read about. And so when people are having behavioral health crises, more often than not, the police have limited tools to deal with that. They have to take them to the hospital or they arrest them. They don't have the same flexibility that behavioral health specialists do. So I don't see anywhere in here where you're saying you can't use police. Am I wrong about that?
No, that's correct. We were very careful in the language of limiting the interaction of law enforcement with individual in crisis. That even means you might have police around the corner, ready in case, right? But it's the interaction that you're trying to limit. So we were very precise with our language for exactly what you're saying. And so that within the context of that as the guidance, locals could figure out then how they make the decision about the specific role for police.
Thank you.
Thank you. Maura Cyphers, followed by Delegate Riley.
Thank you so much, Madam Chair. I think I'm here on behalf of NAMI Maryland, and the one thing I want to add is that when we talk about it, it sounds binary, but it's not. There are different protocols and response levels and co-response models. So law enforcement plus, behavioral health crisis response are totally acceptable. And I think, maybe that's getting lost in the discussion a little bit. So I'm happy to share with the subcommittee some, honestly, they're like graphics that help show like when law enforcement should knock first, when law enforcement doesn't need to come, when people need to go together, because there's different iterations. And I think, what we're trying to get at is that if this is a mental health crisis, it really just needs to get to a mental health response. So I think there's probably more flexibility under this grant program and also what we're trying to achieve than, maybe we've sort of presented, because it is tough, I think, for family members who are experiencing crisis to not know what kind of response they're going to get when they call 911, because sometimes it's amazing, and in many counties it's consistently amazing, but that's not the case statewide. So that's what we're trying to achieve.
Thank you. Delegate Riley.
Thank you, Madam Chair. Yeah,
Pleasure.
the answer I might have already received the answer, but I'm not sure. I just want to verify. I'm in Harford County. We have, pretty much a state-of-the-art facility for mental health or addiction in our Klein's Family Harford Crisis Center. So currently, I believe when a police officer is called, they're, under a bill I believe we passed in the last couple of years, where they're able to take them directly to this crisis center. And I don't want that to be jeopardized in this bill of any kind. Is that so? I mean, this isn't going to jeopardize the relationship that our police officers have in Harford County with our Harford Crisis Center.
So I'm going to try to answer this, and someone can correct me. So the bill basically requires the Maryland Department of Health, in awarding the grants for behavioral health crises grant program, to require in their proposal that it includes a response standard to minimize law enforcement interaction, that they must have and develop a written policy. It doesn't say you have to stop doing what you're doing. It just says if you're going to apply for the grant, right, just have a policy of how it is that you respond, which I bet you that they have it already, because every department has a policy of how they respond. It doesn't say the police should not come. It doesn't say any of that. It just basically says have a written policy, which is the standard for, police departments. And what the bill is trying to do is basically to standardize that response, especially because it's mental health. So there's nothing in here, Delegate Riley, that will ruin that relationship.
Thank you very much. Appreciate it.
My pleasure. Delegate Rosenberg, followed by Delegate Chisholm.
Is there, in line with what you just said, Madam Chair, is there someone who has testified or present tonight from the police community who can speak to whether their view as to whether the language in this bill adequately provides for the kind of response enlightened response, if you will, that you've talked about, or that as the standard, or that would speak to the validity of the Baltimore County?
Well,
standard?
Delegate, the Maryland Association of Counties had an amendment that was actually taken, and it's in the bill as amended, is one of the amendments that we have that took that into consideration. I'm looking at the bill hearing and looking at all the testimony submitted, and I don't see anyone like per se from the police association. There is MPS Thomas Thompson, isn't that it? There's a favorable written, am I right or am I wrong?
No, that's Psychological Association.
Psychological Association, okay, so I guess it was just Mako Delegate, and they did, the delegate did take that amendment.
Do you know offhand what the amendment provides or where it is in the bill?
Okay, sure. Erin, you want to go ahead and remind
Yeah,
us?
their amendment was page 3, lines 21 to 23. So the bill is introduced, the department would prioritize proposals with response standards that minimize law enforcement interaction.
Okay.
And that was changed to standards that prioritize mobile crisis units over law enforcement when responding to individuals in crisis.
And that's to give them
That's
the
Mako
flexibility.
amendment.
Correct.
That's the amendment, the Mako amendment, yes.
Okay. Thank you. Thank
My
you.
pleasure. Delegate Chisholm?
Thank you, Madam Chair.
My pleasure.
First of all, here in Anne Arundel County, we have an amazing critical response team as well. A girl named Jen Corbin, who runs it, is amazing. Unfortunately, we all have gotten to know Jen now, but when we're talking about standardized, we're also talking about, like, it's almost like standardized testing, whatever you want to apply that to, means black and white. And unfortunately, none of this is black and white. It is all, when we're talking about a mental health crisis or situation, it all is inherently dangerous. And when we're talking about a bill like this, where we're saying, well, we're going to have these standards. Well, that's easy to say, but in reality, it's very difficult to make that decision, especially in these situations. And when we were talking, I went back and looked, because I remember from last year in March, we had a health or a mental health crisis response person show up at a home where somebody was having a serious situation right here in Pasadena, and they had to call the police in. And when the police showed up, the guy pulled a gun out and aimed at the police. And unfortunately, they had to shoot back at the gentleman. But I worry because of, we don't want to decriminalize this. And I understand that, I really do. We also put very innocent people in danger. And I would love for this bill to be very black and white. But the truth of the matter is, none of this is black and white. Every situation is different. Every situation has potential for danger and even fatality. And I don't know how you write that into the bill. So I know that's not really a question, but that's my serious reservations with this type of bill.
And if I may add, Delegate Chisholm, I appreciate your thoughts, but the science is so clear when it comes to dealing with mental health. I mean, all the studies, all the journals, all the experts, really, they all opine that when it comes to mental health system and law enforcement responding, that it is best to minimize the interaction of the police. The bill as written doesn't say that you cannot have the police. It basically states that there should be a plan of how you're going to react when you send law enforcement into the community and there's a mental health call. It's all that it says, and it basically doesn't make it black and white. It leaves the flexibility to the locals. But if I may say, every mobile crisis unit has policies and procedures when they call the police. They must have that. And this does not change that at all. But I do understand your reservations and but the bill doesn't really box any particular jurisdiction
appreciate
at
that.
all. My pleasure. And I think, and the Mako amendments also kind of address that, but thank you so much for your question. This is the time to discuss this. So I really appreciate you. So next we have Adrian Brindenstein, and then Delegate Bagnall, then Delegate Charkoudian.
Thank you, Madam Chair. I'm Adrian Bridenstine with Behavioral Health System Baltimore. We weighed in and supported this legislation, and I just want to emphasize, put a finer point on what you've all been talking about, which is this legislation does not standardize the type of mobile crisis team model across the state. In Baltimore City, for example, we have a nurse and a clinician that go out, and we really like our model as well. What we are talking about in this conversation is triaging, right? Recognizing that we have different types of mobile response team models, and we need all these different types of teams across our system of care. There are times when we know we're going to need a law enforcement co-responder model, in particular when there's situations that are very dangerous, like some of the things that you have all described. But there are often times where we don't need that. So we need to figure out a better way across the state to triage these calls so that we can have the appropriate team come out and respond in the community. So I just wanted to really put a finer point on that, because I think that's what you all are talking about, and just emphasize this bill is not standardizing the type of team that will go out and respond, and that we need all of those types of teams in our system of care.
Thank you for that clarification. I appreciate it. Delegate Bagnall.
Thank you, Madam Chair. And thank you for the opportunity to talk about this bill. I know that Delegate Charkoudian and I have had conversations about. I had similar concerns to Delegate Chisholm, and I believe that our county executive weighed in on this bill because Delegate Charkoudian did a look back to make sure that this wouldn't impact our current system in Anne Arundel County, because as Delegate Chisholm said, we were confirmed to be best on the planet last year with our crisis intervention team. So I just wanted to make sure that I was clear on that. With
he
Delegate
did weigh in. And Anne Arundel won. Delegate Chisholm is correct, and you are. We won a beautiful prize because of that. But the county executive, he weighed in and supported it, if I'm not mistaken. Right, Erin?
Yes, I have that letter if you want me to forward it to the.
That would be wonderful if you could send it to all of us. Thank you.
Mm-hmm.
So I just wanted to point that out, and also thank Delegate Charkoudian for doing that due diligence and reassuring me that this wouldn't impact our current system in Anne Arundel County.
Thank you. Any other questions? Let me look and see. Any other questions or concerns? Adrian Bridenstine, your hand is up. Did you mean to bring it down? Thank you. I appreciate it. Okay, wonderful. Having had a great discussion on the bill, there are two amendments on this bill. Is there a motion?
Move the amendments.
Is there a second?
Move them together.
It's been moved in second. Any discussion on the amendment? All those in favor say aye. Any opposed?
Aye.
Seeing none on the bill as amended.
Move the bill as amended.
Second.
Second, it's been moved in second. Any discussion? All those in favor say aye.
Aye.
Any opposed? Delegate Shalega, Delegate Chisholm.
Sorry, I couldn't get my reaction button to work.
It's okay.
Yeah, I'm gonna, I sent an email to law enforcement to ask their opinion on it since they didn't weigh in. And, my concern that I've made known is that with all the anti-police stuff going on around, I don't think that's what this is, but I just want to make sure that's not what it is. So I'm going to vote no now, but I may come back on Friday and change it to yes.
Thank you. Thank you for the courtesy. I appreciate it. And whatever you find out, let us know. I appreciate it. So for now, we have no Delegate Chisholm, Delegate Shalega, and Delegate Riley. Anyone else? That's it. Thank you so much. Thank you for the discussion, everyone. I really appreciate it. So we have next House Bill 275. And while Aaron gets us started, after all the discussion last week and the concerns of Delegate Riley, Delegate Shalega, I went ahead and talked to the different parties and to the sponsor, and I urged her to sit down and work with them. When she did, she can give us an update on the Senate bill. And then Aaron, can you tell us the posture of the bill, including the amendments that were accepted in the Senate because it passed the subcommittee unanimous, and also the additional amendment that was put in the House, because I wanted to make sure to address some of the concerns of some of the members as well. And the sponsor was very gracious to work with us. So Aaron, can you get us started? And I want to thank everyone involved, the industry. Thank you so much for being available in the last week or so. And you know, your representatives here, Mr. Manis and everyone else. Thank you for being at the table. The committee really appreciate it. And Ms. McDonough, go ahead.
So there's these were sent as a separate third email to you all. So it's separate, House Bill 275, and it reflects the bill as passed by the Senate with one additional amendment to the definition of food package, I believe. Yes, food package. Delegate Love has actually offered to walk through it with the subcommittee, just because has a lot of substantial changes, and I'm just seeing it before this meeting. So I do know it passed the Senate, I believe, unanimously, but I don't want to say that out of turn.
No, I appreciate it. And they just worked on it up until just, you know, before we came into this meeting. So, and this will save us some time. So welcome, Delegate Love. Can you please walk us through it? And we have the reprint.
Yes, thank you, Madam Chair. Thank you, Aaron, both of you, for all of your very hard work, and to my colleagues, Jeff Bottle and Nick Manis and others with whom I have worked. I appreciate you all. Very briefly, I'll sort of give you the overview and then walk through the bill. As the chair said, well, let me back up. When we last spoke, we talked about two amendments based on concerns that the opponents had. And so we talked about limiting the definition of PFAS to the items in the bill, and about the issue of ports and terminals and those areas where the foam may not be where some would hope it would be. So we've drafted those two amendments. They went into the bill in EHEA. EHEA took those amendments, passed the bill out unanimously. Subsequent to that, WL Gore came back and had two amendments. I accepted them, as did Senator Elfreth. She offered them on second reader on the floor. And so it's now on third reader. With those amendments, WL Gore has dropped their opposition. I spoke with Kaylee Locklear. There are no further amendments there. They appreciate all the amendments that we have taken. And then I also spoke with Nick Manis, and just today we took another of their amendments. And with that, Nick can tell you himself, they have moved to neutral on the bill. So that is the overall posture of the bill. It's on third reader, like I said, in the Senate. So going to the bill itself, I'll walk you through the most recent amendments. On page 3 of 11, the definition of PFAS chemicals. So that says, when used in firefighting agents, firefighting equipment, food packaging, and rugs and carpets. So the limiting definition that we talked about last week. Moving down to G, there's a definition of terminal, again, going to what we had talked about some of those different fires. The department shall adopt regulations. That was an amendment long before that some of the firefighters had wanted. The 2024 date, as I had mentioned to you before, we moved back the implementation date out of listening to some of the concerns.
Delegate Love, as you go through the bill, since we all have the reprint, will you be so kind in reference to the page and the line that you're referring to, please?
My apologies, Madam Chair. That was all on page 3. Madam Chair, do you want me to go through all of the amendments or just the ones?
I do. I want
Okay,
want our members to understand everything and where the concessions took place. Yes.
Madam
Absolutely.
Chair, I think it's page 10 of the reprint. Corresponds to page 3 of the bill with the amendments.
Yeah.
Okay.
So we have, go ahead. If you could go through the reprint and go through all the amendments so that we know what we're discussing, that would be great. Before you do that, one
Delegate
second.
Hill, look from
Do you have a question?
Delegate Hill, look from the separate packet, please.
Are we talking about the bill that came separately, not in the packet, correct?
Yes, the final,
Okay.
you got one final email that was standalone.
All right, because
So
it was in the
references
reprint.
should be to that page 3 of 11, page 4 of 11.
Yeah. So it's there was one in the reprint packet.
Correct.
So it's standalone.
Yes.
Thank you.
Yes.
Should I start over or are we good?
Why don't you do that? Go ahead.
Okay, I'm sorry.
Okay.
Page 3, line 3, the definition of PFAS. So that's the limiting definition that we talked about last week to limit it to just the items in the bill. Then moving down to the space between line 12 and line 13, we have a definition of terminal, because that's, we talk later about extending the time for ports and terminals to transition to PFAS-free foam. So that's the definition of terminal there. Moving down to line 23, the change from the department may to the department shall. That was one of the firefighter organizations requested that. Moving down to line 26, you see we extend the date to 2024. Going to page 4, line 7, that's where we inserted the language delaying the start date of the bill, so giving added time for port refinery chemical plants. So what you see on B1, that September 30, 2024 date, that's consistent with the Department of Defense. So that's the date that they have to shift to the use of PFAS-free foam. And then the next subsection 2, we have an even later date for terminals to ensure that we have the correct foam to put out the fire. And then sub 3 just ensures that where it's required by federal law, it will be used in Maryland. When it's no longer required by federal law, it will no longer be used in Maryland. So then moving on to page 5, between lines 20 and 21, this was something that we heard from MACO and from a concern from Cecil County and then St. Mary's County, and St. Mary's County came in support because this is a buyback provision. So one of the concerns from some of the counties was, as we transition away from PFAS, foam with PFAS, what about those departments? And a lot of departments don't have it, but what about the ones that do? So that creates a buyback program. There has been a appropriation approved in the Senate. And I sent a request to the chair and the vice chair for a similar appropriation for that, so that we can assist our counties on transitioning. Moving to page 6, line 4, you see that we again move the date back, and then we add the language asked by the retailers, so that a person may not manufacture or knowingly sell. So they wanted that knowingly piece in there. Then in C, what we're doing here is ensuring that it's just the manufacturer of the rug and carpet that has to produce the certificate of compliance, that it's not a distributor who doesn't know what is in the rug or carpet. It's only the manufacturer, the one who actually makes it. Again, that was requested by the retailers. Moving down page 6 to line 27, here we have amendments under the definition of food package. Here we have amendments from both WL Gore and the ACC, so that a food package is now defined as a package that is designed and intended for direct food contact and is composed in substantial part of paper, paperboard, or other materials originally derived from plant fibers. That's a definition that is used in a couple other states' laws, New York, California, and Washington. So that's where that language comes from. And then we jump to page 8, line 18. And again, we bump the date back to 2024 and add the word knowingly. Again, those were the retailers' amendments. On page 9, line 29 in C, again, we're taking out the distributor when it comes to the certificate of compliance, so that it is only the manufacturer, the entity that makes the food packaging, that knows what's going into it. So they're the ones that certify there's no PFAS. Going to the next page, subsection D, lines 6 and 8. Again, since that's dealing with the certificate and whether something is in compliance, we take out the distributor, so it's just on the entity that created it, that knows what's in it. And I believe, yep, those are all the amendments, Madam Chair.
Okay, thank you. So I want to go through the people that were on the other side. I want to first start with Jeff Buttle.
Good evening, Madam Chair. How are you?
I'm doing well. Thank you for being with us.
Good. I think the amendments that the delegate went over, that the bill sponsor went over, are substantially, with the exception of one, are what was done on the Senate side, and we certainly support all of the Senate amendments, and the ones that is different, which I believe is on food packaging, I'll defer to the bill sponsor on that. Whatever she wants to do with that amendment is fine with us.
Okay, thank you. And if I have Mr. Nick Manis and Kenny.
Thank you, Madam Chairman and members of the committee. We would like to thank Delegate Love and also you for organizing and get us together, and we appreciate all the amendments that Delegate Love and hopefully the subcommittee will adopt. And we look forward to continuing to work with the committee, you know, over the interim and next year, as how the chemical industry and the state can continue to work together to protect and enhance the citizens of Maryland. So we thank you.
Thank you so much for working with us. We appreciate it. Ms. Caitlin McDonough.
Thank you, Madam Chair, and I'll add my thanks to Delegate Love for working with us. I did have one technical question that came up with one of my clients today, and I really apologize if this has already been addressed because I haven't been in every single conversation. On page 7 of the reprint, I believe that's right, in lines 28 through 30, it restates the definition of the PFAS chemicals. And my client's question was just whether that needed to be made identical to the previous statement. I mean, excuse me, the previous definition that's listed, I think on page 3, lines 3 through 5, just whether they need to match up. I know they're all part of the same environment article, so I don't know if they need to match or if we need to repeat it or not, but because they do have different definitions, they just wanted to flag that as a technical fix. And if there's a reason for that, that's fine. I just need to explain to them.
Madam Chair.
Yes, let me call on council, okay? Thank you, Erin.
I was just looking at it and I just got the question too, but I think the one section of law is related to firefighting agents. That one section of the code, the other section of the code is not. So that might be the reason why the definition is altered in one spot and not the other.
So I think my reason, so if I go up to, yeah, so in the first definition, excuse me, which is page 3, lines 3 through 5, where we list the 3 kind of targeted uses to limit the definition. It does reference like all 3 of the uses. I think the second time it's listed, I know that section deals specifically with food packaging and not with the other uses.
So one has to do with firefighting.
So I don't know, does it not? I know part of the reason we had like tried to limit the definition was out of concerns that to kind of address concerns that future legislation might come in and add uses without revisiting that definition. So if that definition just still exists in the environment article, does that kind of revive that concern? So I don't know if that section only deals with food packaging, if it would only be limited by food packaging, or if we'd need all 3 in there or not. I really, I don't think it's changes the intent or substance. I just don't know, honestly, if it needs to be there or not.
Madam Chair, I'm fine with making them identical.
I don't think it hurts. You can, I would think.
And that would be it. And otherwise,
one second, Ms. McDonough. What are you saying, Erin?
No, I think it could be consistent and not hurt.
Okay, all right. So we can fix that.
And that's all I had, and I'll just join in thanking everybody and, and particularly Delegate Love for all her work on the bill. So thank you.
Not a problem. Thank you so much. How about Mr. Mike Rochford?
Hey, Madam Chairman, again, thank you for your leadership on this. I'd like to thank Delegate Love and Delegate Riley for working with us. Our concern had to do with the food packaging provision there. And just be clear, it's intended for direct food contact. We don't make food contact materials, but we do use materials are used by the pharmaceutical industry to make vaccines. And just to be clear, on lines 27 and 28, this would apply to our products. They are not made with food packaging, not made with paper or paperboard, but they are used with a PFAS. So I think that would cover us in terms of our concerns.
Yep. Thank you. Who else have I not called from the industry? Can you raise your hand, please? Anyone else? I don't see anyone else. You can unmute yourself. I don't want to miss you or disrespect you. It's not meant to be disrespectful. Go ahead.
Thank you, Madam Chair. Sean Swearingen, I couldn't find the hand button, but just echoing everybody else's sentiment, really appreciate Delegate Love and everybody else in the subcommittee and both chambers for all their work this past couple of weeks.
Thank you. Thank you for being at the table and working with Delegate Love and our members. We really appreciate it. I'm going to call on Delegate Belcastro and then Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Love, for all your work on this. My mind just keeps going back to the hearing and how we learned that PFAS are getting into our water and harming us, how it's affecting our sea life, our animals, and how it's deeply impacting our firefighters. And so I just have a question about all of these amendments, particularly when it comes to distributors. Is your original intent of the bill still intact with all of these amendments?
Thank you very much for that question, Delegate Belcastro. Yes, it is. It absolutely is. I think this will protect our firefighters. I think this will cut down tremendously on PFAS that are entering our waterways and our bodies. And I thank you for that question.
Thank you. Delegate Hill.
Thank you, Madam Chair, and Delegate Love and the other stakeholders. I really do appreciate this. And I'm going to, similar to Delegate Belcastro, particularly with respect to the food packaging and what was can you just clarify for me what this does with respect to food packaging and what pack? So when I think of food packaging and PFAS, I'm thinking about the meat and that white plastic foamy stuff that is not derived from plants. So what is this bill doing with respect to food packaging with all these amendments, please?
If I may, that was
yes.
Nick Canis's request. So I'd actually defer to him to answer that question.
Sure. And I'll briefly describe, and I'll let Sean, who's with ACC, finish. But what it does, it mirrors the other, as Delegate Love said, the other states that have passed similar legislation and mirrors the FDA, what their definition of food packaging. And I'll let Sean further describe it if you would like, Delegate Hill.
Mr. Sean, will you please be so kind and address the question?
Thank you, Madam Chair. So there's a question on the packaging. Again, this does reflect what the FDA is regulating and what their phase out plan is. It also reflects the other states that have targeted this and enacted their own legislation that's very strictly focused on the food packaging in this area, like California, Washington State, and New York. And even Washington State, if I can expand a little bit, their Department of Ecology was tasked to look at an alternatives assessment, and they announced some of the findings from their phase 1. And this will help with some of the examples. They're looking at wrappers and liners, plates, food boats, pizza boxes. They looked at 10 total application products, as well as bags and sleeves, bowls, trays, French fry cartons, clamshells, and interlocking folded containers. So I think your exact example would probably be the bowls and trays or wraps and liners in those segments.
So I'm not clear. Are they excluded from the bill?
No, those are included.
So what's included in the bill are any food packaging that's not derived from plants that contains PFAS, but plant-derived packaging that contains PFAS is not covered?
No, it includes food packaging that is in part or most of from, I can't remember exact terminology, but pulp-based type product.
So the plastic things I'm talking about, which I don't believe are pulp-based at all, those PFAS-containing products we're doing nothing with. Is that correct?
I cannot speak if they have PFAS to it, but these are these examples I gave are within the definition that the Department of Ecology in Washington State are looking at.
Okay.
And they are using the same definition.
Ours is limited and our language is similar to those other states.
No, I understand that.
Yeah, it does not.
I understand it's the same as other states. I still would like to know where food packaging is concerned, what that means, because most food packaging that I think of isn't the pulp-derived food packaging. So maybe no one can answer, but maybe someone can get an answer for me. It's nice to know it's what other state does. That doesn't answer what toxins we're leaving in our food packaging and which ones we're not. So that's what I'd like to know. Thank you.
Sure, and I think that they can get it. And then for full disclosure, this was an amendment that was used like the other states in order to bring people to the table, right? In order for us to negotiate and try to compromise. So there's going to be something left out that's not included. And we can get it for you, but in full disclosure, this was a compromise.
Absolutely, understanding the value of that, but I would like to know how much we gave. to get.
Absolutely.
Thank you.
Delegate Shalega.
Thank you. What is the federal, I know the feds are working on regulations or have done it. Can you tell me what the dates they're using? And I had it in the bill. There's something that talks about the federal law, but I can't seem to locate it now. Do you know that where it is in the bill? And can you tell us what the feds are doing on this issue?
Delegate Schlega, on page 4, that's where we have the language with respect to airport, port, refinery, or chemical plant. The bill all along has exempted BWI. There are some federal regulations around airports. So that's what that was. Federal government is looking at that. So that's why subsection B3 says, if the feds require it, you have to use it. And if they don't, you don't. What I mentioned, the Department of Defense, that's up at B1, September 30, 2024. That's the date that the Department of Defense is moving away from using PFAS foam.
Okay. Yeah.
And Emily, if I misstated any of that, or Jeff, if I misstated any of that, please jump in and correct me.
No, you're correct, Delegate. The October 24 date has to do with the Department of Defense changing their mill spec to phase away from the use of PFAS foam. So they're going to start phasing away from it now, but the hard date is October of 24 to get rid of the foam for DoD use.
Okay, thank you. And I do want to say how wonderful it is that you guys have all worked together to work this out. My last question would be, have you guys talked to Acme? Has anybody talked to Acme Paper? Are there a Maryland business that makes probably these food containers? Are they aware of any of this? What's going on with this? And do they have an opinion, or does no one know?
Delegate Schlega, in the 2 years that I've had this bill, they've never reached out to me, so I don't know.
Okay, all right.
And the bill has been out there.
I was also just going to add, I can't say for absolute certainty, from what I do know, Acme Paper doesn't use this in their products. There is only one manufacturer that is known to use this. That's your time. This is not the time to Sorry for the loud kid.
Delegate, thank you, Delegate Shalega. Delegate Kaiser.
Thank you, Madam Chair. And I think I have my baby going for a few minutes. So let me ask a question. I wanted to follow up on Delegate Belcastro's question to Delegate Love, and maybe what Delegate Hill was getting at as well. My sense of the amendments were that they were dealing with the things that have alternatives that are not sky high costly as compared to the things that don't have alternatives. Would you say that that's a simplification, but a broad explanation of maybe of how you approach the amendments?
Yes.
Okay. All right. Thank you.
Okay. Anyone else? Does anyone else want to be heard on this bill? All right. Delegate Kaiser, you have a question, or the hand, you forgot your hand? Want to make sure I'm inclusive. Okay, thank you. All right. I just want to take a minute to say thank you for working it out. And when you walk away and you don't get everything you want, I think we got somewhere. And I just want to thank you for your time. So on the amendments proposed by Delegate Love, may I have a motion, please?
Move favorable.
May I have a second?
Second.
It's been moved in second. Any discussion or concern? Seeing none, all those in favor say aye.
Aye.
Any opposed? Seeing none, on the bill as amended, may I have a motion?
Bill as amended.
May I have a second?
Second.
It's been moved in second. Any discussion or concern? Seeing none, all those in favor say aye. Oh,
Aye.
Delega.
Sorry, my buttons aren't working very well today. I just want to discussion, say thanks for working with everybody. I'm not in love with this bill, but I'm going to support it just because you've been able to get everyone together at the table, and I hope that it isn't resurrected next year. So thank you.
Not a problem. Any other issues or concerns or discussion? Seeing
Just
none.
want to say thank you.
Oh, go ahead, Delegate Lewis.
Thank you, Madam Chair. I just want to say thank you to the sponsor. This is important, and I'm glad that we're moving forward. Thank you, Madam Chair.
My pleasure. Anyone else? All those in favor say aye.
Aye.
Any opposed? Seeing none is unanimous. I want to take a minute to say, Delegate Love, thank you for your hard work and for being flexible. The committee really appreciates it. And I want to thank all of those involved, everyone at the table, for your time and your commitment to make it work, okay? I hope you have a blessed evening, and the committee thanks you.
Thank
All
you
right?
for all your hard work, Madam Chair. Thank you.
My pleasure.
Committee, I appreciate all of you.
Thank you.
You're welcome.
Good night.
You can thank your mom for her advocacy.
Thank you.
Bye.
Take care.
Thank you. We have a whole list of other bills. We have House Bill 370, sorry. House Bill 370. Erin, can you tell us what the bill does? And I believe that is Delegate Bill Castro, so you can be ready to address us. Erin?
Yes, there are no amendments offered on this bill. The bill requires the Secretary of Health to issue a new birth certificate for an individual if the department receives satisfactory proof that the parent listed on the original birth certificate has undergone a sex change or has had an intersex condition. The new birth certificate issued may not be marked as amended or show that a change has been made to a sex designation or, if applicable, a name. The bill removes the requirement for a licensed healthcare practitioner to determine that an individual's sex designation should be changed for the purposes of issuing a new birth certificate. Instead, an individual must make their request for a change of sex designation on the certificate under penalty of perjury. When issuing a new birth certificate for an individual as authorized under current law, the Secretary may not be limited to designating the sex of the individual as male or female, and when requested under penalty of perjury, must designate the sex of the individual as non-binary, other, or unspecified.
Thank you, Erin. Delegate Bill Castro.
Thank you, Madam Chair.
My
So the main point that I want to make is that this is a simple bill, and it would simply align our procedure of how we handle name and gender marker changes on driver's licenses with how we handle birth certificates. And the main provisions of the bill, they are not anything new to what we already practice here in Maryland. Again, we're doing it already on driver's licenses. And the final point that I want to make before we go into discussion is that birth certificates are identity documents. They are important identity documents. We utilize these to establish parentage, enroll our students in school, obtain healthcare benefits. So it's really important that we make these changes and individuals' name and gender markers are accurately reflected, just as they are on driver's licenses, also on birth certificates. And with that, I'd be happy to take any questions.
Yes. Thank you so much. Are there any questions for the delegate on this bill?
Move favorable.
Second.
Okay, it's been moved and second. Any questions or concerns? Okay, seeing none, all those in favor say aye.
Aye.
Any
Aye.
opposition to this bill? Seeing Delegate Chisholm, Delegate Riley, and Delegate Shalega. Okay, anyone else? Let me see. There's 2 pages, I'm sorry, of people, so please be kind with me. Just hold on a second. All right, thank you. The bill passes. Thank you so much for being here, and thank you, CP Huffman, for being here. We appreciate your testimony. We have actually the following bill is actually House Bill 378. Maryland Healthcare Commission Palliative Care Services Work Group. Erin, can you tell us what the bill does, please?
Yes, there are no amendments on this bill. It requires the Maryland Healthcare Commission to convene a work group to study and make recommendations to improve palliative care services in the state. The work group is to include representatives of hospice and palliative care providers, healthcare facilities, patient advocacy groups, and health insurers. They'll submit an interim report by July 1st, 2023, and a final report by November 1st, 2023, including the need for any legislative initiatives.
Is Delegate Kerr here? Does he want to be heard? I don't think I see him. Are there any questions or concerns regarding this bill from the committee?
Move the bill.
Okay, I don't see any. It's been moved. May I have a second? Okay, any questions or concerns? All right, all those in favor say aye.
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 Wonderful. Thank you. Any opposition? Seeing none, the bill passes unanimous. Great. And then, Erin, I think I just lost my, oh, here it is. My agenda, I got it. The next bill is House Bill 578. And for those of you that are wondering, I don't have enough space on my desk today for all these files. So we have House Bill 578, Maryland Medical Assistance Programs, prior authorization for drug products to treat an opioid disorder prohibition. Erin, tell us what the bill does.
Sorry, I had to unmute myself and then re-find the bill. The bill prohibits Medicaid and the Maryland Children's Health Program from applying a prior authorization requirement for a prescription drug when used for treatment of an opioid use disorder, and that contains methadone, buprenorphine, and naltrexone. The sponsor did have amendment at the bill hearing that I forgot to include in your packet, but this bill would not apply to the Maryland Children's Health Program. You all did discuss the bill last week. I know representatives from MDH were here to discuss the rebate program, and the bill is back before you this week.
Okay. Delegate Kaiser and then Delegate Nsika.
Thank you, Madam Chair. I certainly wish I had the same kumbaya story that Delegate Love was able to share with her bill. We did meet with MDH last Monday to try to work through some of the details and try to figure out if there were ways to find a way to provide these opioid use medicines to Medicaid patients in ways that those with private insurance get it. Everything we were told that we were trying to do, be it with generics or name brand, everything we were told would be too costly. I appreciated all the expertise that we had, and we did learn a few things, but ultimately it felt like we were trying to find some way to help the Medicaid patients get these medications quicker, and really there weren't any creative solutions that were offered. So we are still at an impasse. I do think Ann Seacott has some things to point out, and I do know that both Delegate Johnson and Delegate Hill have their expertise on this matter, but I'm still hoping there's a path forward.
Thank you. Thank you for trying. Nsika.
Thank you, Madam Chair, members of the committee. I echo the sponsors, gratitude for the discussion. And this is not an area that I think is simple. A lot of the things you all do aren't simple. I think the concern is in part that there's a concern that the loss of rebate money is so significant that it would outweigh, the lives saved potentially when it comes to people being able to access treatment. In the budget for the Behavioral Health Administration, it was recognized that there is such difficulty with getting enough medication assisted treatment, getting people access to medication assisted treatment. I do not at all want to propose that this is the solution, that this bill solves all of that. It does not. But I think that given some of the barriers that exist, some of which I'm not even sure we're clear about what exist, I think making sure that the prior authorizations remain not a barrier is a good policy. It's recommended by a lot of national organizations, and I don't want to challenge the expertise of the folks at Medicaid. I do want to say I think that they are presenting a worst case scenario on the budget impact. I'm not so convinced, but they, I'm not as convinced that it's going to cost quite as much money as they fear.
Thank you. Any questions from the committee? I have Delegate Johnson, Delegate Hill.
Thank you, Madam Chairman.
My pleasure.
And thank you, Ms. Seacott. I have a question. I really have a concern when we start looking at rebates and discounts that we're putting money over patients. And my question is, we've only looked at one side of this equation, I feel. If we applied this, we're not only saving money on the medications, if we applied this to all medications, brands and generics, I would like to see the physical analysis that includes the savings in paying for the generics. So can you talk to us at all on that, Ms. Seacott?
I mean, I don't have those numbers, of course, but I think the thing that you're pointing out is that if we said no prior authorization for brand names or generics, I know that Medicaid's concern, what they expressed has been that there's a concern of the loss of rebates. If more generics are sold, then there's less brand where they have the rebates. So there's a loss of revenue there. I don't know if that has been balanced by how much would be saved by purchasing generic products. So that might be a question for the department.
So I know Ms. Roddy's here. Tricia, are you able to please, and thank you for coming. We really appreciate it. Appreciate your time. Will you be so kind and address us regarding the concerns that were just discussed by Delegate Johnson?
Yeah, and I think Athos is on the phone as well. I think when we spoke last, the rebates that are generated make actually the brand name drugs cheaper than the generics. So again, it's as what was mentioned, it's a very complicated process in terms of these negotiations, but they actually end up to be cheaper than the generics in this negotiation.
Thank you, Madam Chair. We hear that a lot. Thank you for the answer.
Okay. I have next, my pleasure, Delegate Hill, followed by Delegate Bagnall.
Thank you. Delegate Kaiser, appreciate this bill. And we had talked about some things, and I know you were taking it back to the department, and obviously they didn't, I don't know if they didn't say yes or they're still thinking about it, but what I'm really wondering, and I would like to know what their response was to that final proposal that we had, the default to the brand. And my understanding is only 5,000, at least from what Atlas said, there are only 5,000 prescriptions out of, I don't know, 130,000 that we're talking about. So the numbers don't quite add up for me. So the second part, so that's one to Ann, and the second part to the vice chair, the chairman of the subcommittee, is it possible for us to use this or to some way get that study done that Delegate Johnson was just asking about, either through this vehicle or another one, to actually ask for a study that tells us when we talk about the cost of folks not getting the medication against the cost of whatever rebates we're getting on the brand name? How do we, that we can somehow get that information from a letter from the chair or something we need, for how we, whether it's for next session or not. But this is a problem. And if we don't solve it this year, it's going to still be a problem. And so, so that's the second part. And then I think there was another part, but maybe Ann, you can just start with that first part.
So we put in writing a number of arguments to the department, and the response was that any way you slice it, they believe it's going to cost too much money.
Okay, and then my question to the department is the contract you have for these rebates. When does that contract expire?
So at those, I believe there are annual negotiations that occur. And again, obviously then you're getting into, I think this was one of the suggestions that Ann was bringing up, you wouldn't want something that violated state law in terms of your contract. So again, no matter how you slice it, there's still going to be a fiscal impact.
Thank you.
Okay, Delegate Bagnall.
Thank you, Madam Chair. And I just want to sort of circle back where we left the conversation, because there were a lot of ideas on the table. And I'm just wondering, if they just were a dead end. We talked about the possibility of sort of a reverse authorization, where if the generic requires pre-authorization, that pharmacists would have the authority to reverse it to the name brand that has the rebate. There was also a question about whether if this is really an access issue where the name brand is what's on the preferred drug list, if we are finding that we don't have enough, to meet the demand, that we could then put the generic on the drug list. I'm just wondering where those conversations ended, because it does feel like there's got to be some sort of solution for this problem.
And I don't think, go ahead.
I'm happy to, add some insight. So, just in general, we can't give you the specific rebate that we negotiate, but we have told Delegate Kaiser and Ann that it's upwards of $15 million. It's over $15 million. So even if even if you sort of any reduction of that, even if it's 50% reduction, you're still talking $7.5 million at least in terms of a fiscal note. So these are real savings that that state Medicaid programs realize. It's one of the only tools that we have on the fee-for-service side that generate substantial savings from the drug manufacturers. What I will say, what we're willing to do and what we've offered to do is, if there's additional outreach, I think Delegate Hill talked about, those prescribers that are still using the generics, if there's additional outreach that we can do to let them know what the benefit is if they use the brand name drugs that are on the preferred drug list in terms of easier access and authorization, we're more than happy to do that.
Thank you, Madam.
Okay, any other questions? Delegate Hill, your hand is up. Are you going?
I'm sorry, I do have one more question.
Okay.
And it gets back to that specific recommendation that Delegate Bagnall talked about and that we talked about in the committee, and I know Ann proposed. So what was wrong with defaulting to the brand name with whom we have the contracts? You said something, I think, in the meeting about, well, then they would know that we will be using them when we lose our leverage, but you're already saying that we're trying to get everyone to use them. And even when we go through pre-authorization, they're being approved. So I'm not clear on how defaulting to where we're going to go and just skipping the pre-authorization step is going to cost us money. We're still going to be using the brand name with the contract and getting the rebate we're just saving a couple of days of pretending that we're going through a pre-authorization process because of some medical thing. We're just doing it to get from the generic to the brand name.
So, I mean, part of the negotiation, right, is the idea that you're going to steer more utilization to your drug, right? So in essence, the idea is that if you require authorization of the generics, you're going to steer them towards the brand name drugs and increase the utilization. And because of that, the drug manufacturers will give you additional monies and rebates. And so it'd be fine to educate providers to encourage them to use the preferred drug list. That will not reduce those rebates. They actually might increase them.
I'm sorry. I know things are getting late. I don't mean to be dense.
Listen, I have Delegate Hill.
Okay.
I have a proposal, okay? And this is what I'm proposing. I'm proposing, Tricia, that if you can make yourself available like you did, and we're very grateful with Mr. Athos, and the main sponsor of the bill, Ms. Delegate Kaiser and Seacock, and I would want you to meet, please, with Delegate Hill and Delegate Johnson and Delegate Bagnall. Anyone else want to meet? I want you to have a little subcommittee of the subcommittee, and I want you to look at the following: whether we could do a reverse authorization, okay, and make this bill into that, or whether we should make this bill into a study that will look at the number of prescriptions. What are we really talking about here? How many? Okay, because that would tell us the number, okay? And some of the, the other issues that have been outstanding. If you could do that, please, I really would appreciate it. Can you do that, please, Tricia?
Oh, absolutely, we'd be happy to.
And the delegates that I just referenced to, are you willing?
Yes.
Okay, thank you. So what I need to do is, Delegate Kaiser, I need you to do an email with Delegate Hill, Bagnall, Johnson, Tricia, Athos, and Seacock, and yourself. And I like you to please work on something, because there's something that needs to be done. And this is how I feel about it. I feel that we passed similar legislation in 2017, and it actually, requires the private insurance to do it. And we understood then and now that it's life-saving to some people. They can't wait. And it is having that and making that delicate balance that is important. I understand our fiscal responsibility, but life, what price do you put on a life? And I think that should come into the equation, especially given that in the last almost 3 years, the number of people that have overdosed and have died has gone up because of COVID, right? Because they were home and they couldn't cope, and there's such depression, and there's also many people that are committing suicide. And I just really feel that this is a time to sit down and see if we can compromise. So I will be extremely grateful if you could do that, okay? Delegate Kaiser, do you want to be heard?
I just want to echo what you said, and thank you, Madam Chair, about the value of life, because I do understand the fiscal argument and the cost of the rebates, but it seems like there's savings from the generics, there's savings from the reduced other health and mental health needs. And then, like you said so eloquently, it's also about the cost of a value of life. So thank you. We'll make the meeting happen.
My pleasure. Is there anyone else from the committee that wants to be part of it? Anyone? Okay. All right. Feel free, even afterwards. Delegate Hill, your hand is up. You still want to say something?
No, I'm just getting ready for the next bill.
Okay, thank you. Okay, we have House Bill 588, Local Health Department and Community Action Agencies, Feminine Hygiene Products. Erin, can you tell us what the bill does? And Delegate Bagnall, please be ready to speak.
If you look at handwritten page 22 of your packet, this is the bill as amended. The bill would require that during fiscal years 2024, 2025, and 2026, each community action agency, in collaboration with appropriate local health departments, shall make available at the agency feminine hygiene products in an amount sufficient to meet the needs of the woman obtaining the products. The agency may not require payment for the products that are made available. And for fiscal years 2024, 2025, and 26, the governor shall include in the annual budget bill funding in an amount estimated to be sufficient for providing the products. On or before December 1st, 2026, the department is required to report to the General Assembly and the governor on the implementation of the bill. And the bill also sunsets in 5 years.
Okay, Delegate Bagnall.
Thank you, Madam Chair. And I think there might be a piece missing in that amendment, because it also should have been amended to a pilot. And where we are right now is determining 2 to 3 locations that would be the most successful for piloting the program, so that part of that study is analyzing how best to move forward. And also that we have spoken with, as I said in the hearing, we have spoken with the health department, who are happy and ready to work directly with the community action agencies on the implementation and on an implementation plan, so that we are that we're setting this up for successful implementation and working with the community action agencies, rather than telling them what to do and then telling them, and then making them figure it out.
Okay, so I have a question for Erin. Erin, is it drafted as a pilot?
I had in my notes that Delegate Bagnall at the hearing said, make it a pilot and still working on identifying regions. So this does not identify regions. I looked in our amendment system and I didn't see that you had done any more or requested any more. So
I apologize. I'm not sure where that amended language where we got lost in translation, but we definitely had worked with with Dr. Polsky and with Mr. Percy, who are both on this call, and determined that starting it as a pilot would be rather than trying to do a statewide effort would be the most successful.
So why don't we do something, since we don't have the amendment? Let's quickly discuss it. Let's hold it. We have time, and work on the amendment, please, and bring it back. Okay?
Absolutely.
But because they're here, I want to hear from them, but I don't want to put Erin on the spot like that, because she has a lot going on. Okay?
No, absolutely. That's clearly, we lost something in translation, and I apologize.
It's okay. It happens. It happens. So Dr. Polsky, would you like to be heard on this bill?
I'll keep this very brief. First off, I want to thank Delegate Bagnall not only for bringing forth an important bill, and when I was still in full-time clinical practice, I had low-income patients who had very heavy periods, to the point where they would go through a pad or more every hour, and not being able to afford products oftentimes meant that they had to miss several days of work every month. And so this is an economic issue for low-income women, not just the cost of the pads, but also how it affects their ability to get to their jobs on a day-to-day basis. And I want to thank Delegate Bagnall for understanding for local health departments that it's not just the cost of the products, but it would be a substantial administrative cost for us. So we are more than happy to work with community groups to lend expertise. And as we do with the Maryland Diaper Bank, where we refer the clients, patients that we work with at local health departments to our community partners, so that low-income families can get the resources that they need.
Thank you. Does anyone else want to be heard on this bill? You can unmute yourself.
Yes, good evening. Good evening, Madam Chair. Davion Percy with Percy Public Affairs. On behalf of the Maryland Community Action Partnership, we are working with Delegate Bagnall to identify the 3 locations, community action agencies in Maryland. There are 17 of them serving the 24 jurisdictions. And because historically my client hasn't tracked this data, it's taken us a little longer to identify the 3 pilot locations, but we expect within the next 24 to 48 hours to have those locations identified. Everything else in the bill looks good. We may discuss with the delegates some technical questions and amendments, but overall we support the bill and we'll identify the pilot locations and be able to move forward. So thank you for sponsoring this bill, Delegate Bagnall.
All right, and before I hold it, any of the members of the committee, do you have any questions or concerns that you would like the delegate to address before we bring it back? Delegate Szeliga.
Thank you. Mr.
pleasure.
Kersey, community action, can you tell us what they are? I'm sorry, I lost the words because I'm flipping back and forth between screens.
Yes, absolutely. So community action agencies are nonprofits that are federally and state designated as community action agencies. They that designation allows them to receive community service block grant funding that is aimed at serving the lower income communities and communities in need throughout the entire United States and for us throughout the entire state of Maryland. How they operate is they conduct community needs assessments every 3 to 5 years to determine what the needs are of those in the community who are most in need. And that's how they determine what services they provide. And so in one area of the state, it may be homeless shelters. In another area of the state, it may be job services program. Other areas may be childcare programs. This was enacted under Lyndon Johnson. And when he declared his administration declared a war against poverty, and they created this community action agency program. So that's generally what they are. And so because of that, we haven't been tracking, or my client hasn't been tracking this particular need for feminine hygiene products, but they are now going to start to track that so that we can determine exactly where the need is, which is why we support the pilot program, so that, if there's an area of state where the need isn't as great, we don't have to put the funds towards that area, but focus the funding on an area where the needs are greater.
That sounds great. Well, thank you. You said there's 17 of them in Maryland?
Correct. So there's 17 of them in the more populated counties. They serve one county. In many of the rural areas, they serve multiple counties.
All right, that'd be great. I would love to see a list of them. Thank you.
I can provide that to you, sure.
Okay, thanks so much.
Would you be so kind and send it to Erin so she can send it to the entire committee?
Yes, Madam Chair.
Thank you so much. Thank you, Delegate. Any other questions? Okay, we're going to hold the bill, and then Delegate, you know what you need to do. Okay, and we'll put it back. Thank you.
Thank you so much.
We appreciate you. Next, and thank you so much for being here. Next, we have House Bill 609, Local Health Officers Removal Grounds and Process. Erin.
The bill would repeal the provision that specifies that the health officer for a county serves at the pleasure of the governing body of that county and the Secretary of Health, and instead enumerates specified reasons for which a health officer may be removed from office with the concurrence of the governing body and the appropriate county and the secretary. Those reasons are for immorality, misconduct in office, insubordination, incompetency, or willful neglect of duty. The bill also requires the secretary to provide written notification of removal to a health officer and authorizes a health officer to appeal a removal decision to the secretary and to the Office of Administrative Hearings. There's a reprint of the bill in your packet. If you look on handwritten page 25, after line 26, this pulls in current law under the state personnel and pensions article that provides that certain employees serve at the pleasure of the employee's appointing authority and may be terminated from employment for any reason that is not illegal or unconstitutional, solely in the discretion of the appointing authority. That the amendment states that this would not apply to a health officer who's appointed under 3302 of the Health General Article, which is the section of code that this bill is amending.
Thank you. And basically the goal here is to better insulate health officers from increasing outside pressures. We have all seen it, regardless of where we stand in life or what, politically, how we feel. And it's, public health is public health. And they need to feel comfortable The fact is that although they are politically appointed, if a new administration comes, they can keep them. And they're not like most political appointees that, can get fired immediately. And this is viral, the way this bill is drafted, like the superintendent of education, which when you look at our budgets here, the majority of the money we spent are on education and health and public safety. And we must insulate them. And that's the reason why Senator Lamb and I, put in the bill. I will let Dr. Polsky speak, and then if there are any questions, we'll address it. Dr. Polsky.
Thank you, Madam Chair. And the health officers around the state realize that this is never a position that will be completely apolitical. But as the chair mentioned, the goal of the bill is to minimize the politics that go into healthcare decisions. And I think we all appreciate how important it is for healthcare professionals to be able to do what is right. And I will say that for me, every resident of Calvert County I see as my patient. And just like when I see a patient in the office, I don't take a public opinion poll as to how I should treat their cancer or treat whatever they're coming in with. It's based on the best science that I have at my disposal. Sometimes that's directly from my background. Sometimes that's from speaking to other physicians, other healthcare professionals in my community and at expert organizations. And again, the goal of this bill is to make sure as much as possible that health officers can base their decisions on the best science. And so I'm happy to answer any questions if the members would like.
Thank you. Is there anyone else that wants to be heard on this bill? Are there any questions from the committee members? Seeing none, on the bill as amended, may I have a motion, please?
The bill is amended.
May I have a second?
Second.
It's been moved and second. Any questions or concerns? Okay. All those in favor say aye.
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 Opposed on the amendment? Oh, wait a second. Were there, Aaron, we had amendments, right?
Yes, you did.
Yeah, I forgot. So I was moving the amendments as the little hands kind of threw me off. Okay. All those in favor on the bill now as amended? All those in favor say aye.
Aye.
Any opposition? I have Delegate Chisholm, Delegate Riley, and Delegate Shalago. Delegate Robin Lewis, we can hear you.
Sorry.
It's okay. Anyone else? Thank you so much. Next, we have House Bill 669. And just to remind the members, there's also House Bill 765. And if you recall, the delegate testified and said he didn't mind rolling his into 669. Just to, out of respect, I want to let you know that. And we did hold it, and I asked the sponsor to work it out. She has a couple of amendments. Aaron, will you be so kind and describe 669 for the committee? Then Delegate Wilkins, I will call on you and I would like you to walk the committee through the amendments, please. And then we'll open it up for discussion for the members. Aaron.
This bill requires the Maryland Department of Health to ensure that doulas providing care under Medicaid are participating doulas, review participation in Medicaid of participating doulas and program recipients, and evaluate the effectiveness of doula services covered by Medicaid. The bill also establishes requirements for participating doulas and specifications for coverage of doula services. This bill was discussed last Monday. There is an amendment on page 27 that clarifies that doulas supplement services of healthcare providers and provide counseling and not coaching. The amendment on page 28 was the amendment proposed by the Health Services Cost Review Commission that clarifies that the bill may not be construed to limit their authority to set appropriate rates for hospital services. The amendment on page 29 strikes the definition of postpartum period and also strikes the references to the doulas providing home visiting services. The amendment on page 30 is the amendment that has been proposed since the last subcommittee meeting, and I was able to run a reprint of the bill that just incorporates that amendment on page 31, on page 30. So that begins on handwritten page 31 of your packet. If you look on handwritten page 32, the definition of doula services that begins on line 3 provides that doula services mean continuous and non-clinical physical, emotional, and informational support. If you go down to line 25 on handwritten page 32, the bill as introduced had a definition of medically necessary. That has been altered to provide that it would be medically indicated, which means that a service or benefit meets the coverage requirements set by the department. And then throughout the bill, when there's references to medically necessary, that has been changed to medically indicated.
Thank you, Erin. Delegate Wilkins.
Thank you so much, Madam Chair.
Walk us through, please.
Sure, yes. All right, so Erin just went over the amendment just to give you sort of an overview. These amendments satisfy, I believe, some of the comments that have been raised. So one of them is dealing with making it clear that doulas are providing non-clinical services. So as Erin mentioned, we added the word non-clinical there, which let me give you exactly where it was added, which is it would be added on page 2, line 3. So that it's clear that it's non-clinical services. On the same page, it makes clear that it's supplementing the services of the healthcare provider. That's still on page 2, line 7, adding the word supplementing the services of the healthcare provider, starting after the word guidance. We also removed the word counseling and replaced it with coaching. Madam Chair, I don't know if you want me to go, Erin kind of went over it, so I don't know if you want me to go through.
Yeah, I want you to go ahead, go through it and explain to us, who were you addressing and what issue it was.
Got it. Okay, sure. Yes, so we changed the word from counseling to coaching there, again, to make sure that it was clear that the services of doulas are coaching services, not actual clinical counseling. And then last week's conversation centered on the words medically necessary and wanting to be clear that doulas are not providing medical services. And this was something that, thank you so much, Delegate Hill, worked with Scott Tiffin and myself to help figure out, instead using the term medically indicated. That starts on page 2, line 25, where the word necessary is crossed out and indicated is put there instead. And the definition also mentions that it must meet the coverage requirement of the department. So the intent there is to make sure that it's something that is indicated by a clinical provider, that the doula is not on their own providing medically necessary services. At the request of MDH, I'm now on page 3, starting at line 10, we had removed the definition of postpartum period, given some work that MDH is doing on that and not wanting this to interfere with it. So that was a request by MDH. And you'll see again the term medically necessary replaced with medically indicated on page 4, line 7. And then finally on page 5, starting on line 8, we also removed home visiting services, which was a request of MDH. Just again, to make sure that when we use home visiting services, that can mean something else in terms of the work of Medicaid and the Department of Health. So just to make sure we don't have any confusion, that was a request and just a small technical change that we made there. So I believe those are all of the amendments. And and finally, HSCRC's suggested amendment that makes clear that this bill may not be misconstrued to limit their authority and set in rate setting. So I believe these amendments should address the various discussion points, and that is how they came about.
Thank you so much for your efforts and for addressing the members' concerns and meeting with people. Now I'm opening it up to the committee members. Are there any questions from the committee members regarding this bill? Delegate Shalega.
Thank you, and thanks for working on it. Remind me what the certification program is. I know on handwritten 33, a couple spots in the bill, it speaks of certification. Delegate Wilkins, just remind me what that is.
Sure. So there are several programs that doulas are able to participate in to be certified to become a doula. In the not in my bill, but in the regulations, it lists out which specific programs. So what I did in the bill was just a reference that you have to receive the certification, but we left it up to MDH to determine the specific programs that they would accept.
Okay, thank you. I just couldn't recall. There were a couple of testimonies that were favorable with amendments. So I'm assuming you worked with them. Oh gosh, sorry. And I couldn't see what amendments they wanted. The birth cooperative both said favorable with amendments, but maybe they just meant favorable because it didn't seem like they had any suggested amendments. Did they talk to you?
I think some of those folks made, because I presented amendments at the hearing as well. I think some of those folks were just referencing some of the technical
amendments that you had. Okay, because
yes.
I'm like, they said favorable with amendments, but they don't say in their testimony, this is what I want the bill to do. Okay, finally, I'm a huge supporter of doulas. I would like to see some kind of conscience clause put in there. I think we discussed it maybe at the last subcommittee meeting. Erin, can you remind me about where we are with that?
Yeah, I thought I sent the link to the statute at the last meeting. It's 20-2014 of the Health General article, which says that no person can be required to provide or participate in an abortion.
Yeah,
that again.
Okay, yeah, it was required to perform an abortion.
But also participate is in there. That the word participate is in that section.
It says participate
Correct.
or perform, because I certainly want to make sure that I don't know whether we need to repeat that in this bill. I don't know if you would be averse to that, if there could be some indication in language that is something that you, Delegate Wilkins, would be willing to put in the bill, or if it would be necessary, just some indication that yes, indeed, doulas would not have to participate in abortion.
Madam Chair.
Yeah, I would. You want me to address it? I would say that it's not necessary, Delegate. Section 2214 of the Health General says that a person may not be required to perform an abortion, and it's already covered. It's the law. It's our law. We have it already. This issue has already been addressed already, and there's two parts of it. One is for the provider, and one is for any individual as well. So it's already in the law. And if you want, we can send it to you again, but I know we
no, I had it in my notes.
Yeah.
Thank you. I found it.
Yeah.
Okay.
And Madam Chair, if I may.
Yes.
I just wanted to underscore that participating in Medicaid is completely optional. So no doula would be required. This is a program where if you would like to, be reimbursed, a doula can voluntarily participate. So I think that because this is a completely voluntary program for doulas who get the certification, who provide the services and get reimbursed, I can't see a scenario in which if someone would be forced or compelled to perform some kind of or participate in some kind of procedure against their will.
Thank you.
Thank you. And thank you for clarifying that. I appreciate it. And I appreciate the conversation. Any other questions or concerns? Okay, seeing none on the amendments, may I have a motion, please?
Move the amendments.
Second.
It's been moved in second. Any questions or concern? Seeing none, all those in favor say aye.
Aye.
Any opposed? Seeing none on the bill as amended, may I have a
Bill as
motion?
amended.
It's
Second.
been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, the bill passes. So we're back down to our last bill of the day. And actually in House Bill 765, we're now going to act on that bill. That bill is, a lot of the provisions were rolled into 669, correct, Erin?
Yeah, so I just moved the sponsors from 765 onto 669.
Wonderful.
And
we'll give the sponsor an opportunity to withdraw his bill.
Okay.
Okay, if we can send him an email and ask him to please withdraw it.
Sure.
Thank you. The last bill is House Bill 684, Maryland Medical Assistance Program, Psychiatric Inpatient Care, Admissions Restriction, Psychiatric Hospital Admissions Equity Act. Erin, can you tell us what the bill does? And then Delegate Bagnall, can you please be ready to speak, please?
The bill would prohibit the Maryland Department of Health from limiting or restricting admission of a Medicaid recipient for inpatient care at a special psychiatric unit or an acute general care hospital with separately identified inpatient psychiatric service, unless the department bases the limit or restriction on the medical necessity of the admission and establishes the limit or restriction through regulation. There were no amendments offered.
Delegate Bagnall.
Yeah, in essence, it's prohibiting bringing back a policy that was an inequitable policy. It was necessitated by a federal limitation, which has now been lifted. We now have access to the waiver program, so we just want to ensure that any policies going forward are medically relevant. And there were no amendments, and we had no opposition.
Are there any questions from the committee members about this bill? Do you have any concerns or questions regarding it? Seeing none, all those in favor on the bill, may I have a motion, please?
Move the bill as amended.
Second. There are no amendments. Second. It's been second. All those in favor say aye.
Me.
Aye.
Any opposition? Seeing none, the bill passes unanimous. This is the end of and Pam, I'm so sorry you were here and I didn't call on you on the doula bill.
I didn't need to say anything. It was all well handled. Thank you, Delegate Wilkins.
And Megan as well, and Dana. We appreciate all of you that were here today. That Heather Sheck, thank you for being here. And Heather, thank you for working with Delegate Wilkins on the doula bill.
My pleasure.
Wonderful. I just want to thank everyone for your work today. I know it was a long night, but I think that we discussed it and discussed things. I want you to feel that you can ask the question. And if we have to hold something, we'll hold it and then come back. So thank you for your input. I value it. And I hope you have a blessed evening. And Erin, thank you for your work. And my wonderful, wonderful right hand, Edith, thank you for being this late, okay? Have a blessed evening, everyone. Take care.
Thank you, Madam Chair.
My pleasure. Thank you.